This is Chillin with Chitnis, our June, can't believe it's June already, our June 2022 installment of Chillin with Chitnis. My name is Shelly Korean. Warm welcome to all of you. Thank you for being here. As you guys know, this is really just intended to be an informal conversation to give you access to a movement disorder specialist if you have questions on things related to PD. We know that those wait times between doctor appointments can be really long. And so we want to give you guys access to ask your questions and also ask each other questions and give access to a community of folks that are perhaps experiencing some of the same things that you guys are going through. Tonight, we are going to be discussing living well with Parkinson's, and that includes social interactions, employment issues, as well as time management. Really, that's just a response to some of the questions that we received from you guys. I know that a lot of you are dealing with some of those issues firsthand. And while we have that topic to guide our discussion, we're not limited to that. So if there's anything under the PD umbrella that you want to ask, please feel free to do so. We want to make this a free-flowing conversation, informal, and make sure that we get your questions answered. We got some great questions with registration related to the topic as well as outside of the topic. So thank you guys for submitting those, and we'll address those later on in our time together. But for now, let's go ahead and jump in and we can get started. Thank you for being here, Shilpa.
Thank you, Shelly. Hi, everybody. How's everybody doing? Today is not my best day. I spent all day with my head spinning, trying to see patients. So if I'm a little off, you know why. I already told Karen that to warn her. So I want to ask a question. We'll try to make it a little interactive. When you were diagnosed first with Parkinson's disease and you were still employed, did you feel that you had an obligation to tell your employer?
And you guys can answer this verbally by unmuting yourselves, or if you're not comfortable doing that, you can put it in the chat box too.
So first, I was obligated to tell them what I did. I had a lead position in a company, and I wanted to make sure that they knew why I was doing what.
Were you worried that that would affect your job or your ability to make progress in your career?
No, I wasn't worried, but it did. Within a year, I was having trouble walking, and
so
they wanted to put me on long-term disability. I filed in court one time and lost some.
Yeah, I'm sorry to hear that. Well, here's the important thing. It really, it's really up to you. It's not like if you were diagnosed with diabetes, like, would you go and tell your employer that? Would you like jump up and say, oh, I got diagnosed with diabetes? Haha. You wouldn't do that. If you got diagnosed with hypertension, you got diagnosed with hypothyroidism, you wouldn't necessarily, I mean, when I got diagnosed with rheumatoid arthritis, I was a fellow at LSU, and there was no need for me to necessarily tell anybody. Now, it just depends on what you do for a living, what is going to be required of you physically, and what is going to be required of you cognitively. But really, in the early part of the disease, for quite a few years, as long as you are doing everything to take care of your Parkinson's disease, and nobody can fire you for not telling the employer that you have Parkinson's. This is your personal health information. What you do with it is only your business. Okay, it's not something that, now, of course, the big challenge is that, if you are walking and your hands start shaking, if you're sitting in a room and you're having a discussion about, oh, our company just lost $10 million, and then you're stressed and your hands shaking, then these are things that, I have a patient who tells me that one of her relatives, who's also a physician, always comments on, why do you walk like this? Like, why is your ankle like this? And she feels really nervous because she doesn't want to necessarily tell anybody. So I think that, this I think is really a very personal choice. It also depends on what kind of a relationship that you have with your employer. For example, I'm professor of neurology at UT Southwestern. If I got diagnosed with Parkinson's disease, until I'm able to do my job well, until I'm able to, I mean, of course, my job entails a lot of talking and a lot of typing. And, I'm only in clinic, so I'm not running from one place to the other. Um, it would just depend. I would just have to see, w- if that was something that I wanted to tell or not. So don't feel any obligation. It's your personal decision. Number two, that you should not be discriminated against because you have Parkinson's disease. I can tell you tons of stories of the AIDS epidemic. My PhD was in HIV, pharmacotherapeutics, and I cannot tell you how many patients were so scared to tell their employer that they had become HIV positive, although they did not have AIDS or defining illness per se. And as soon as the employer found out, because of lack of knowledge, really, that just being around a person with HIV doesn't give you HIV, and because of lack of knowledge, how many people lost their jobs. And it's crazy, and it should not be like that. So I think that at least, I'm not a lawyer, but you can definitely talk to a lawyer and they can tell you what the laws are regarding these things. Like nobody should you know but unfortunately, human beings are such that people just tend to be judgmental, and suddenly, now you've told your boss that you have Parkinson's, and they're always going to be like, well, is Chitnis going to be able to do her job? So our society needs to have a different view and needs to have a exactly similar view about Parkinson's disease. Like if somebody had cancer, right, and they were undergoing chemotherapy, like everybody would be like very sympathetic, take time off, do this and that. Parkinson's disease is no different. I mean, sure, it's a motor disorder, but I see people that are very well controlled with the disease, being able to work their job. I have a guy in my practice. He's young onset. He's been working for 15 years. He, has a really, really high profile job. I think his employer always knew. But the critical thing to remember here is you have to take very good care of yourself. If you want to be able to really continue to work for quite a few years and do the things that you enjoy, then you have to get really serious. And I was in clinic this morning with somebody, very nice guy, very nice patient, a lot of respect for them as a person, but super non-compliant with everything that they needed to do. Do you take your medicine like with a full glass of water? I do not. Do you wait a whole hour before you eat? I do not. Are you how many days a week are you exercising? Once a week. How what is your diet like? Well, I eat whatever I want. And then do you do speech therapy? And I just do it like once a week. So what does Dr. Chitnis do with this, right? I mean, I cannot come to your house and make you do things. uh, I can only tell you the things that you need to know. And so if you are diagnosed with Parkinson's disease today on day one, then you just have to basically figure out. I mean, somebody that's diagnosed with, I mean, I keep bringing diabetes, because it's a silent illness that nobody can see. But if I were to be diagnosed with diabetes, I would be like, oh my God, I have to lose weight, and I have to change my diet. I basically have to take my medicine, all of those things. So um, Parkinson's disease is no different. And I will tell you, based on my experience of being a Parkinson's doctor for over 20 years, and now here at UT Southwestern for 15, 16 years, I can basically pick my patients who got very serious from day one, who started exercising very regularly, who did all the right things, who ended up getting deep brain stimulation at about 10 years, 8 to 10 years since the onset of symptoms, and are still working at year 15. Now, there are many phenotypes of the way Parkinson's disease progresses. There is a very mild phenotype. I have people with 20 years of disease that are still just maybe in stage 3. And then there is a moderate phenotype, and then there is a little rapidly advancing phenotype where it's a little bit more malignant form of the disease, and the patient starts to develop non-motor symptoms quicker. They start to develop gait and balance problems quicker, and that's hard. But yet, I think that the most important thing really are like having a good plan. And obviously, everybody's job is busy. My job is super busy. Um, but I think that charity begins at home. If you don't take care of yourself, you're not going to be able to work for the years that you want to work. But if you decide, you plan and say, I'm going to decide a certain, and I think there is something to be said about regularity. And I promise you, I'm the last person to give a lecture to anybody on regularity, because for 24 years of my married life, I have been trying to emulate my husband and get up, early in the morning at 4 o'clock, like he does, and try to, ride my bike at 4 o'clock, read my journal, eat breakfast, sitting at a table rather than in the car. And I'm just not an early morning person. I've tried for 24 years. I've tried very sincerely, and it doesn't work for me. So the way I figure out my life is, and I'm not sure what time I will go to sleep. Like, last night I went to sleep at 2:30 because I stupidly agreed to help a friend with a project that I didn't have time for. And I basically said yes. And then 2 weeks passed and I hadn't done it yet. And they're like, hey, we need this by tomorrow. And guess what? I mean, the only way I could do it is by staying up late. So, I don't like that. I've gotten better about time management. So you need to decide, like, what works for you. So if you want to get up in the morning, I mean, the things I enjoy when I do them is I get up in the morning, I do a little bit of yoga, I do a little bit of like meditation thing. I have this Indian religious thing that my mom taught me that I do. And it really makes me feel calm. I can tell that I'm a different person when I do those things. Um, and essentially, so you have to decide, but if Dr. Chitnis tells you, you really have to at least exercise 30 minutes a day, 5 days a week, then you have to figure out the time of the day when you are at your best, when you feel well. It can be like me at the end of the day when I have seen 20 patients and I come home and, and it's like 7:30 and I'm dying and I'm still trying to get on my bike and, then can't do it. And on clinic days, I just can't exercise. So you have to really figure out, what is the time of the day when I am at my best. And in early disease, this should not vary. In advanced disease, it can vary. It depends on, sometimes people are worse at the end of the day, or if, your medication starts to wear off. But you have to come up with a plan. And the plan is, and, mix it up. You don't have to do, the same exercise every day. You don't have to ride the elliptical every day. You could do yoga one day. You could do, weights one day. You could just take your dog for a walk one day. It's a little hot outside, but you can certainly go walk in the mall. And then you can, ride the stationary bike one day. So you got to mix it up. Unless you're like a couple of my patients who are really hardcore exercise fiends that I actually became during the pandemic, you have to kind of mix it up. And, of course, there is that research that tells you if you ride the bike at, certain revolutions and you got to get your heart rate, we're not professional athletes. We're like normal people. And, for normal people, like, we should be able, if you can do something regularly, 30 or 40 minutes, 5 days a week, I'll give you a high five. My magic number is 5. Okay. My magic number for most things is 5. 5 days a week of physical exercise, at least 5 days a week of speech therapy. Those of you all who know Samantha Ellendery at the Parkinson's Voice Project will tell you that Samantha will disagree with me. And sometimes ask my patients, how many days of the week do you eat? And they look at me like, Chitnis lost her marbles. Like, what kind of a question is that? Of course I eat every day. So if you eat every day and you want to be able to retain your swallowing ability and you want to be able to, not choke and cough and aspirate, then, perhaps you should do your speech exercises every day. There is logic in some of these things. So I think that it's really important, but, like Shelly said, one of the topics we're going to talk about is time management. You literally have to sit down. I literally sat down during the pandemic and wrote down things I need to do for work, things I need to do for myself, things I need to do for my family. And, I'm very proud to say I stuck with it. I've lost weight. I cook very healthy meals. I spend time with my daughter. Last night at 2:30 was just a aberration. I don't do that anymore, and you have to set limits. You have to be able to say, no, to things. We are always all, we are eager beavers. We want to please people. We want to please people at work. And, you basically just going to have to say, I don't have the bandwidth, and your plate is going to be overflowing. And, the most important person that you will have to take care of is really yourself. You have to fix your sleep, you have to fix your nutrition, you have to fix your exercise, and these things I think are very important. Any comments?
Shilpa, I think Lynn had a question going back to employment. Lynn, do you want to ask your question?
Way back when you said that people know cancer and they pat you in the back and say, well, you'll be all right. I found that people don't know Parkinson's. They don't know what's going to entail. I didn't know what it was going to entail. And it became hard for me to manage and keep it secret from other people. So that was just an aha I had. And people don't know Parkinson's.
So I think, you're right, but, perhaps this is what we should all be doing. Perhaps we should, start educating people about our condition. And one of the things that I, tell my patients to empower them is, you haven't done anything to get Parkinson's disease. Okay. It's not like, you smoked something. I have very young people. When I was a neurology resident, I had very young boys, 22 years of age, that came in after a bout of cocaine with a hemorrhage in their head. And then, they're paralyzed and they're, repentant because they shouldn't have used cocaine. And, of course, I'm still not judgmental, but, you could say, oh my God, I wish you hadn't done that. What have you done to get Parkinson's disease? Nothing. Like, I think there is no reason, see, this is like going through the 5 stages of grief. People are different in ways in which they cope. Okay. When I was diagnosed with rheumatoid arthritis, I was only 38 years of age. I just had a child, and, it was horrible. For 5 months, it was horrible. I could not write. I would come home and literally, thankfully, my parents just happened to be staying with me at that time. And I would come home with the amount of energy that I normally have, come home, lie on that one couch for months, and I couldn't do a lot of things. I immediately got on medication, but the immune medications take, time to basically act. But, I was too young to feel sorry for myself. I just had a kid. I just starting out my career. So I figured out what all I needed to do, to start getting better. And, I basically used my friends and my family and all the support system I had to adapt and cope. And, 5 months later, when my medicine started working and I was better, I was like, you know what, I'm in remission now. Let's go. Like, this is done. I'm gonna, every month, and tomorrow's my appointment, every month, I religiously go and get my infusion. I spend an hour and a half in the Aston clinic and I get my infusion. And guess what? That keeps me healthy. If you look at me, if you ever meet me, you will not be able to tell I have rheumatoid arthritis. With Parkinson's disease, people have tremors. Sometimes, you're not swinging your arm, you're dragging your foot. And so people notice these physical changes in you. But the more you empower yourself, and, this is a process, it's not going to happen on day one. I think that, even for me, it is hard when I tell a patient that, I think you have Parkinson's disease, and I feel really bad when they are not with a friend or with a family member, because, it's a lot to process, So my goal is to be as empathetic as possible to the patient, to encourage them, to make them feel that, they can do this. I mean, we're all going to get something. I mean, I don't know anybody that got out of life alive, right? I mean, everybody is going to be gone at some point. So, we should all be warriors. While we're here, we just own it. Like I said, we haven't done anything wrong, but we should really take care of ourselves. And, we should really find a good, movement disorder doctor. Now, sometimes people don't have access to movement disorder doctors, but I would say so much to travel somewhere. Go and find a fellowship trained, if you can travel, go and find a fellowship trained movement disorder doctor, get a really good consultation, get a copy of their note. We can all access our notes on my chart, and then make sure you read it, make sure you make a plan based on what they tell you, and then maybe find a local neurologist in your town that is willing to work with you. And, but I think the more, I mean, the reason that we are doing this, Shelly and I and Victor, we are doing these webinars is because we want our DFW Parkinson's community to be the most educated community in this nation. We want everybody to know as much of the disease as possible so that they can, take very good care of themselves, right? So I think, it's really important that, you figure out what are the things that you need to do. And, don't do this alone. Like, people start isolating. Sometimes people just don't want to see anybody. And that's, initially, you just reacting to having been diagnosed with a disease. But I think, the best thing that I've found is that at the Parkinson's Voice Project, and Pat knows this, at the Parkinson's Project, there is these number of couples, and they all kind of, while the patient is doing the the speech exercises, these spouses, whether men or women, are all sitting around a table, getting coffee, chatting. My daughter used to volunteer there, and I would go and sit and chat with them. Build a community for yourself. Find like-minded people who understand what it is that you're going through, and be a source of support for each other. I remember that one of the patient's wife, forgetting his name, Pat will tell me, my brain's not working. She was working at school. And I think that, Pat and some other people would pick him up, take him to his therapy, take him to his speech therapy. And, we're only going to do well in life if we help each other and take care of each other. It'll take you time to build your support network, but if you can find a good support group, don't hide, just go meet people. Your experiences and what you share with other people is also going to help them. Sometimes people may not know. I mean, somebody, was talking about how much shoulder pain they were having and they didn't know what to do. And, and then somebody just sent me a message saying that, hey, you're a Parkinson's doctor. I have this friend, they just have a lot of shoulder pain and they can't figure out, and they've had neck MRIs and everything. And I said, what's their blood pressure like? And they looked at me like, wow, what does that mean? I said, please ask them this question. What is their blood pressure like? And, take their blood pressure at different times of the day. And guess what? Their blood pressure was 80/50. This is, low blood pressure or orthostatic hypotension that develops in Parkinson's patients. Normally this develops in the later course of the disease, but there are enough patients I've seen that develop early onset symptoms of, these are called autonomic symptoms, whether urinary problems or constipation or blood pressure fluctuations. And I said, have them drink a lot of water, have them add a salt to their diet, at least for now, and then have them get in touch with their doctor. They may need a medication. And then, they had high blood pressure before they were diagnosed with Parkinson's, and they were on blood pressure lowering medication. So essentially the disease was dropping their blood pressure, the age was dropping their blood pressure, the levodopa, carbidopa was dropping their blood pressure, and then they're taking lisinopril, that was dropping their blood pressure. So they held their lisinopril, they did all the things that I did. Guess what? Their shoulder pain went away, right? So if you know this, and if somebody comes and says, I have shoulder pain, and you heard the story, or this has been your experience, and you share it, it's only going to help another person. They're going to get better. We have to, like Victor says, Victor Abraham, who owns Kapas Foundation, and says that a candle only gets brighter when it shares the light. So, we don't have to share light. I think we can also share darkness. I think darkness becomes brighter when we share it. I think, we all have our dark moments.
Absolutely, Shilpa. Thank you. Just want to address a couple of things in the chat before I get to a question that actually a few questions that came in about social interaction.
Yeah.
Kenneth says, Kenneth and a few others direct messaged me and said that they exercise regularly. They've got the whole time management thing down, but they're really struggling with fatigue and the accompanying frustration that comes with that. Any tips or advice?
Yeah. So, fatigue, the causes of fatigue and Parkinson's disease are multifactorial. Firstly, that it is part and parcel of the disease. It's like rheumatoid arthritis has fatigue, Parkinson's has fatigue, multiple sclerosis has fatigue. Number of diseases have fatigue as part of the disease. And it may start early in the disease, or it may, be when you have more severe disease. So it's hard to say. So basically, I try to fix first the things that I can fix. So I want to make sure that, they're getting adequate rest, and sometimes people have sleep disorders. they have obstructive sleep apnea, they're not able to sleep at night, and they wake up in the morning and they feel fatigued, then they're fatigued all day, right? They have headaches. So I think about, what is their sleep like? I want to fix basically their sleep. I want to make sure that they are hydrated. I tell the people to eat small, frequent meals rather than eating big meals, because big meals will make you feel more fatigued. The blood sugars go up. So things you can fix. Sometimes, people who are not exercising and have fatigue, and they start exercising slowly, their fatigue can get better and can go away. Now, after you've done all of these things and you still have fatigue as an integral part of the disease, then I think there are some medications that can help with fatigue. One of the medicines, amantadine, that we use in patients with Parkinson's is very commonly used in multiple sclerosis patients and for fatigue. So sometimes I'll use amantadine. Sometimes I will use, I don't use Ritalin, but Ritalin, can definitely help with fatigue. Provigil and Nuvigil, these are, alerting medications. They sometimes help with fatigue. So there's number of different things, but we always look for correctable causes, things that you can fix, and then take it from there.
Absolutely. Just real quick before we move on from employment, there were a couple of resources that were shared in the chat box. Thank you, Karen, for sharing that resource. I think it was Texas Workforce Solutions, and I had put a note in there for Jewish Family Services as well, and they offer career counseling and coaching specifically to people with all types of chronic illnesses and disabilities. So I will send out a message to everyone that's on this group chat, I'm sorry, on the Zoom, and a group email to everyone with some of those resources, if hopefully that'll be helpful.
Yeah, no, this is very helpful, Shelley. We should probably start creating a document of, these kinds of resources, right?
Yep, we actually are collecting resources, and there is a document that's in the works. Before I get back to the chat here, we got a few questions about social interaction. A common problem that a lot of people expressed was experiencing increased tremors in social situations, and trying to stop it obviously makes it worse. Any suggestions to mitigate that?
Yeah, so, the honest truth is that tremor in Parkinson's disease is very unpredictable. Even my best control patients who are best controlled on medications, or who are even very well controlled on DBS and medications together, under circumstances, if you're too hot, if you're too cold, if you didn't eat, you didn't sleep, if you get in an argument with somebody, if something stressful is happening at work, it's going to bring out the tremor. So there's really no perfect answer for that. What I do suggest to people is that if you're really conscious and you are, going out and worried about your tremor coming out, make sure that you try to be as much as possible in the on state, meaning that, your medicine's kicked in and is, lasting the number of hours that it lasts. So sometimes, I don't recommend people to pill pop, because that's not a good strategy. But more so, you get up in the day and then plan your day in such a manner that you're as close to being in the medication on state as possible when you go out. That way, at least you'll have, or sometimes, if you are taking, let's say, 2 tablets of levodopa and you want to go out with friends and you're worried about something, it's okay to take 2.5, as long as you're not having side effects, just a little bit more and go. But trying to being in the on state is good. Now sometimes people will put their hand underneath their behind and sit on it and manage the tremor that way. But if you're going to eat and you need both hands, then you may not be able to do that. So recognize that there's no perfect solution. For tremor will not go down to 0. Even with DBS, it can sometimes come out. I mean, with DBS, of course, and medications is the best that I've seen tremor being managed. But there are lots of situations, and social situations, especially if your friends or if people you're going out with don't know you have Parkinson's, just creates nervousness and brings out the tremor. So I think it's kind of part and parcel of the disease. Try the strategies that I suggested, but if it comes out, it comes out. Don't worry about it. What else? What can we do? That's tremor is very unpredictable and come out anyway.
You have to make sure the bartender knows you're not drunk. It happened twice.
Yeah, yeah. Yeah, I mean, I've seen some patients, in social interactions who basically, say, hey, I have Parkinson's disease, I take medications for it. My symptom is tremor and comes out once in a while. Sorry about that, I mean, I'm trying to empower people to get to that level of acceptance of, we can't change the card that's dealt to us. So I think, the better, go to counseling. I mean, if acceptance of the disease, coping with the disease, especially initially, is a problem, please go to counseling. I make this joke. It's not funny, but, I was telling a patient yesterday, I said, my simple philosophy of life is, as soon as a child is born, they see the mom, they see the dad, they see the grandparents, and the next person that they should see is Karen Brewer-Mixon. You should see a cognitive behavioral therapist. I think that everybody needs psychoanalysis and everybody needs psychotherapy. I think, we should all go to psychotherapy if we only had, 100 of Karen. Isn't that right, Karen?
Well, I'm not sure that I need to see infants, but yeah, I mean, I get your point. I was thinking when you were talking that if a person has any kind of social anxiety, which happens a lot with people in the population, but also with people that have chronic illness, and particularly with Parkinson's, we're seeing it. There are treatments for that, and that anxiety will make tremors worse too. So you do have some ability to reduce that with psychological treatment, and usually that's a few sessions with a psychologist who understands Parkinson's. So it's not like a huge commitment, but still.
Yeah. And there are medications. Some people will take like Paxil. It's approved for social anxiety disorder. It's a medication. It's an antidepressant, anti-anxiety medication. Some people might actually take Inderal. Inderal or propranolol is basically a blood pressure lowering medication. What happens is when we get anxious, a particular neurochemical in our body goes up. That's called epinephrine, norepinephrine. And so Inderal basically damps it down. So people, sometimes if people are very nervous trying to give a talk in front of large audience, they'll just take 10 to 20 milligrams of Inderal, and that kind of calms them down and calms down the tremor. Of course, the Parkinsonian rest tremor is different, but I still think that Inderal can help in certain circumstances. Unfortunately, Inderal can also drop blood pressure. So it's always pros and cons, right? But I think if you really have social anxiety disorder, I know you need to see a psychiatrist, need to get a diagnosis, need to get treated, and optimize with your medication, and perhaps that helps. So that's a good point, Karen. But coping strategies, coping mechanisms, I highly recommend that it's not a bad idea to see a therapist. It's I'm very fond of therapists because I think that they make a huge difference. In fact, I think going to therapy is harder than taking medication. Okay, going to therapy, you address your abnormal beliefs, your abnormal perception. I'm not a psychologist, I'm talking like Karen. Address your abnormal beliefs, your abnormal perceptions, and the therapist can really help you, recognize what you're doing that you shouldn't be doing. They can give you some, things to avoid triggers. They can give you some coping mechanisms and tips. So, it helps. I mean, I think it's really, really important.
We do have some questions that came in with registration, but want to give a chance to those who are joining us live. If you haven't submitted a question and you have one.
So, apparently DAPS has a care partner support group, but they are during the day.
During the day.
I know Parkinson's Voice Project used to also have a, caregiver support group, but I don't know, again, through the pandemic, and we have to kind of regroup and, restart some of these activities.
Yeah. And I'm getting a couple of questions about support groups in Arlington, Fort Worth, Grapevine. I'm not currently aware of any, but I'm making a note to get that information for you guys.
I think there might be. I mean, go Google. I've been able to find some support groups just by Googling, but then, just people that live in these areas, if you have information, please send the information to Shelly so she can put it in a resource document that we can share with everybody.
I had asked, I don't think Dan Novak is on this call. I know that they used to have one in Tarrant County pre-COVID, and they put it on hold once COVID happened. I don't think they've started it up again, but just give me a couple days and I'll get back to you guys with some information on that.
Well, here's another, googly, here's another, suggestion. Start one, that's how a lot of support groups have been started. Somebody decided that they needed a support group. If there's no support group in 20 miles where you live, take the initiative, start one, and just go for it. I mean, if you can find, church space or space somewhere else, or, sometimes even hospitals sometimes will provide, these things. Go talk to the hospital administrators, say, I want to start a support group. Do you have patients with Parkinson's that come to see primary care doctors, other people, start one. I mean, support groups are started by somebody. They're started by people like you guys, right? So start one.
Dr. Chitnis, sometimes I just get so tired of everything I have to do to control my Parkinson's. I have to take Rytary at this time, I take it this time, I take antidepressant pills, take this. I get tired of it being managing me. I don't know what the answer is, but
yeah, so this is hard, right? I mean, and especially patients who have a little bit more advanced disease that need to take the medications closer together. I don't have a a magic bullet to answer that question. I think just putting yourself on a timer, just making sure that you do what you need to do at certain times. The one thing that I will say is, every so often go to your primary care doctor and try to do a visit where they can just review your meds. Sometimes somebody puts us on a medication for something, or somebody puts us on a supplement for something, and then that just becomes part of your life, and then 2 years later you're on 27 different things that you really don't need. So one of the things that I'll do, so I always regularly look at medications of all my patients when I see them in clinic, and I sometimes say, you don't need this, you don't need this, you don't need this, and go to your primary care doctor and stop taking these, or wean off these, you don't need these. So take a look at the medicines and see what you really need, like what are priority medications. I mean, I tell you very honestly, Dr. Blasek, Amy Blasek will tell you about supplements more than I can tell you, but there really is no evidence like that any supplement, that coenzyme Q10, you could take it for heart, or you could take it for skin. B12 sometimes you have to take if you're taking levodopa, your B12 levels are low. Calcium and vitamin D you have to take if those are low, because Parkinson's patients can be at higher levels, higher risk of falls, and we want to make sure that vitamin D and calcium are good. So there are some things which are unavoidable, and I'm sorry that yes, I mean it gets hard trying to but rather than thinking about the disease managing you, perhaps our mindset should be, how best can I manage my disease so I can be the best version of myself. It's easy for me to say I don't have Parkinson's, but I mean I do have something else, and I have to work with that. We just have to acceptance. I think Karen and I run a program for patients with functional neurological disorders, and at every visit what I tell the patient is, how are you doing with your acceptance? Because if their acceptance is not good, they are just going to look for another neurologist and another answer and another cause, and they're not going to find it, and they're not going to get better. So similarly I say to my Parkinson's patients as well, we have to work on our acceptance. It's unfortunate we've got this, go through the 5 stages of grief if you have to, but I can't allow my patients to have prolonged grief. If they're prolonged grief, that means they're not going to focus on getting better. So form your team. I think it is really important to form your team, and your team really consists of primary care doctor. If you're an older person, find a geriatric doctor, because there are issues related to geriatrics that they know. Definitely a movement disorder neurologist, therapist if required, psychiatrist, speech therapist, physical therapist. Just form your team of people, and reach out to those people for help every so often. Keep engagement, I think, is very important. Karen, did you have something to say?
No, but one of the things that I thought was that it's also really important to plan fun in your life. Um, some, activity where Parkinson's is not the focus at all, where you are watching a movie or going bowling or whatever it is that you can do, that you enjoy and that you do with other people, that makes a huge difference in terms of how you feel about your quality of life. And most of us have to schedule that. It doesn't just happen. We have to plan it ahead. But I do think it's really important, and not just for people with Parkinson's, but for caregivers too. Really important.
I had a patient that had stage 4 Parkinson's, and he developed something else and got into a wheelchair and couldn't get out of it. And I was talking to him and I said, I'm sorry, you that you have to be, stuck and can do a lot of things for yourself. And he said, Dr. Chitnis, one of the things I absolutely loved doing was watching movies. And when I was working, I never got a chance to watch all the movies that I wanted to watch. The way I look at it is now I have all the time in the world. So, I have subscriptions for Netflix and Prime and this and that and that. And I just try to get as much out of watching movies that I missed during my, my lifetime working. So, I learned, I'm very humbled. I learned a lot of things from my patients. They teach me what a nice attitude, right? It's like, oh, don't worry about the wheelchair. I'm just, I'm sure it's something that bothers him, but he's coping with it by, doing what Karen said is, doing something fun that he enjoys. People like eating good food and, eat that, spend time with your loved ones. And, and I will say this to those of you who are, care partners, that don't lose the spouse relationship. I see too many people losing that relationship. The situation and Parkinson's, puts you in that role, but, you didn't marry Parkinson's, right? You married the person. So, if you can ask for help, whether it is a kid, whether it is whether you want to spend some money and get somebody basically, to do the chores, and then you can just sit and, spend time and talk about, relive your journey one day, and think about the trips you took another day, and talk about your kids one day, just you cannot lose that relationship. I think, this is really bad when, patients get disease and the spouse, care partner just becomes in that role, and the fun is out, and I don't like the fun to be out. You gotta keep the fun, the joy, the romance in the relationship. You just can't lose it. These things are really important, for happiness.
Amen to that. Thank you guys for your comments that are coming in through the chat. Switching gears here a little bit, we got some questions in registration about GI issues with Parkinson's, which is interesting because Shilpa, as you know, our topic for our next month's Ask the Doctor has to do with inflammation and the gut microbiome and all of that. Someone asks, does anyone else have increased GI issues since being diagnosed with Parkinson's? Any tips or advice?
Everybody.
Everybody. Constipation. More pills they give you, the more constipation you're going to get.
So let me start right from the beginning. So even before you develop the motor symptoms of Parkinson's disease, people can develop chronic constipation 20 years before the onset of, tremor or stiffness or slowness. The way Parkinson's disease could possibly be propagated, it doesn't really start in the part of the brain that's called substantia nigra, where you have the dopamine neurons. It actually could start in the olfactory epithelium. It actually could start in the gut. So constipation, gut motility is a problem, with patients with Parkinson's disease. On top of that, one of the side effects of levodopa, can be constipation. So it is really important, to manage this. It is really important to drink a lot of water. I suggest for people to drink most of their water during the daytime, and then slowly start dehydrating after 6 p.m. so that you don't have, nocturnal issues. You're not interrupting your sleep by getting up to go to the bathroom. Diet is very important. Eat a lot of fiber, eat a lot of fruits, eat a lot of veggies, and then move. If you don't move, your bowels don't move. The more sedentary you are, the more sedentary your bowels are, and they don't move. Of course, there is a role for lots of medications. We use Miralax, but there's so many different, medications that can be basically used. There's some nice Ayurvedic therapies that I like. There is a Ayurvedic supplement called Triphala. And this is, I grew up in India, and my mother used to give us Triphala when we were kids, and we didn't drink enough water, didn't eat, we loved meat as kids and didn't eat enough veggies, and ended up getting constipated. And she gave us like Triphala, just put a spoon, like a small teaspoon of Triphala, put it in water, and then just give it to us, taste pad. But, it got you going the next day. Prunes, those things help. But, GI motility disorders are part and parcel of Parkinson's disease. Sometimes, people have problems with gastric emptying. There is a bacteria that's called H. pylori or Helicobacter pylori that can sometimes be a problem. It can be very easily treated with an antibiotic. If you have H. pylori and it is not treated, it can interfere with the cinnamate absorption. So, suddenly if whose cinnamate is just working very well and suddenly not working, then, I start troubleshooting and thinking about these things. And it's a simple test that can be done for H. pylori. There are some agents that, there's not a good motility agent per se. One of the agents is pyridostigmine. I sometimes use that. There used to be a medicine called cisapride, but it went off the market because of some cardiac side effects. And there is a really good medicine called domperidone. It is unfortunately not available in the US. I am trying to fill a application so that I can get permission to prescribe this. It's a 1,000-page long application. I'll have to find time for it. But there are some, maybe it's available in Canada. So domperidone is really good. It really helps with motility as well. But if you've tried everything, one of the things Dr. Dewey, my partner, tells patients is take a liter of water, add a cap full of Miralax to it, and drink that in the first 1 to 2 hours from the time that you wake up. And I've had people come back and tell me that it's worked miracles for them. So, there are lots and lots of things that can be done. You have to basically pick your poison, see what works for you,
There's a lot to manage.
Yes.
Going back to the care partner conversation, Barry and Pat shared that the Davis Finney Foundation has a care partner monthly meetup that is very helpful. And the next meeting will be on Tuesday, July 5th. Thank you for sharing that. It reminded me that we actually have a master resource list specifically for care partners that Dr. Mike Brach at Tribe Wellness and I put together. We ran a seasonal caregiver exercise and connect program that just ended in May. And at the conclusion of that, we sent out a master list of care partner specific resources. So I'll send that to this group, and hopefully, and this care partner monthly meetup that Barry and Pat mentioned is on there as well. There's tons of great resources. It might be a little overwhelming. We've tried to categorize it as best as we could so that you can, kind of go through it one by one, but I'll send that out, and hopefully that'll be helpful to you guys that are asking for care partner resources.
Thank you, Shelley. There is one thing I do want to say. There is a very painful condition. It's called anismus, where the anal sphincter really tightens. And this can sometimes happen in patients with Parkinson's. And sometimes, this can be helped by injection of low doses of, botulinum toxin or Botox that is used for treating wrinkles. And it helps, relax the sphincters. So somebody said something about sphincters. So I just wanted to put it out there.
Very good.
And it's kind of like it's like a dystonia. It's a dystonia of the anal sphincter, that really tightens up. Hopefully nobody gets it. Can be painful.
Shilpa, what are your thoughts on focused ultrasound treatment for PD?
Yeah, so focused ultrasound or high frequency ultrasound has been approved by the FDA few years ago, and it is approved for treatment of unilateral, one-sided tremor. That is, it's really for patients who have tremor dominant Parkinson's disease, or patients who have essential tremor, or people who have other kinds of tremors. So in Parkinson's disease patients, it is a treatment for tremor. It can only be done one-sided at this time. there are clinical studies that are going on to see if they can do, bilateral. This is very similar to the thalamotomies that they used to do in the past, except that the modality is just it's a high frequency ultrasound machine that they use. You're in an MRI suite, and they basically target. And we have a very good program, Dr. Bhavya Shah at UT Southwestern. So if there is a patient that has very unilateral asymmetric Parkinsonian tremor that is not that is refractory to even the high doses of levodopa, or response to levodopa, but those doses cause side effects, then you can certainly be a candidate. A lot of times we do deep brain stimulation because DBS is has been approved since 2003, and is we have lots of experience with DBS. You have long-term experience with DBS. We don't have that much long-term experience with HIFU or focused ultrasound, but I'm sure we'll develop it as we're doing more and more cases. It actually recently also got approved for another target. So for tremor, it's called the VIM nucleus of the thalamus. And then it has also been approved for unilateral GPI or pallidotomy in patients that basically have dyskinesia, or patients who have stiffness or slowness of movement, but it's still unilateral, it's not bilateral. And some patients don't want to get DBS. I mean, it's not that you're not a candidate for DBS, so let's try focused ultrasound. Some people just don't want to put wires in their brain, and they're like, I'm one-sided, I have tremor as a symptom. So what we do in our neuromodulation clinic is we basically look for appropriate candidate selection. We make sure what symptoms the patient has. We make sure what the patient's needs are, what the patient's expectations are. Are they a good candidate for DBS or not? Do they want to do DBS or not? And then we make that decision. It's a really thoughtful and long process. Of course, remember that once you burn a hole, then it's done. It's not reversible. Deep brain stimulation, we can turn off the device and it's completely reversible. With high frequency ultrasound, it's not reversible. Therefore, it has to be done very diligently. Dr. Shah has an extra step that he goes through where he uses a radiological technique to really identify the tracks, so that see, when you stimulate a part of the brain, you could end up stimulating surrounding parts of the brain, can end up having side effects such as slurred speech, can have motor weakness, can have sensory symptoms, can have balance issues. So it has really to be done very, very carefully, but certainly is a treatment modality.
Does anyone else joining us live have any questions? Don't be shy. You can put them in the chat box if you would like. I'm communicating with some of you guys on here.
Well, I just fell, put my dog up, and I would have been hurt if I hadn't had a grab bar. The SkyPass put in. What I did just right here.
Yay. Thank you, Lynn, for sharing that. What Lynn is referring to is our PD assistance program, wherein we fund mobility assistance devices like wheelchairs, walkers, and canes. And we also coordinate and fund grab bar installations in homes of people with Parkinson's. And Lynn was actually our first client for grab bar installation when we launched this a couple of months ago. And Lynn unfortunately suffered a nasty fall in his home and reached out to us, and we were able to get somebody out there. We've partnered with DFW grab bars, and they are a great resource and extremely experienced and helpful. And they got some grab bars installed in Lynn's home, so he can navigate safely. Thank you.
They've helped me.
So somebody asked me about the Fisher-Wallace stimulator. I honestly have no experience with it. I've never used it. Has anybody used it? I haven't. I have never used it. Any other question, Shelley? Let me make sure.
Kenneth says, my UT Southwestern doctor said no DBS because I had a time of hallucinations a couple of years ago. He said these negate DBS, now taking Nuplazid, so no hallucinations.
Yeah, so, hallucinations can develop in patients with Parkinson's disease that are taking a lot of medications. The medications can cause hallucinations, but sometimes having hallucinations can also indicate a worsening of the cognitive status. So people who, have worsening of their cognitive status are at a higher risk of developing hallucinations. And it is not necessarily the hallucinations that are a contraindication to DBS. It is that underlying, cognitive status. If that's impaired, and especially if people have dementia, then they are not a good candidate. And so Nuplazid is one of the newer medications approved in the last couple of years that is very helpful for treatment of hallucinations. You do have to monitor the EKG and do a couple of other things while you're on the medication, but can be very effective. Yes. But just because the hallucinations are gone, that one does not become automatically a candidate for DBS again, because you're just putting a band-aid. The problem still exists. The band-aid is just covering the hallucinations. Let me see. Rivastigmine patch could help me in case of balance and fall. So, there has been some research in the past where rivastigmine is a medication that is used for treatment of cognitive dysfunction or dementia. It is in the category of medicines that are called, inhibitors of an enzyme that is cholinesterase. So this allows, acetylcholine, that is a neurochemical, to basically, stay in the brain longer. So in the part of the brain, which is the locomotor center, and it's actually a nucleus in the brain, I'll just say it's called the pedunculopontine nucleus. Don't need to remember that, but it's a locomotor center in the brain. And the neurochemical there is acetylcholine. So any medication that allows acetylcholine to remain in the neuronal synapse for a longer period of time can potentially help with gait and balance. There have been some studies with the use of these agents with gait and balance, but it has never been, the jury is still out there. I think I've also tried it, and I've not really had earth-shattering experience with that. The other problem with using these medicines is sometimes they can drop blood pressure. So, I have to really balance, who do I use these medicines in? Of course, if somebody has cognitive dysfunction, dementia, then I use it, but then I have to balance it with making sure that they do not have lightheadedness and things like that. Now, one of the good side effects of these medications is diarrhea. So patients with Parkinson's disease really welcome the side effect if they have constipation.
Is UT Southwestern planning any studies for PSP, Shilpa?
I would have to ask. I don't think so. I know Patrick O'Sullivan was doing some study with PSP, but I think they finished the enrollment, and I don't think that the medication did not meet its study endpoints. So I don't think we have anything right now. But I'll tell you, I'm going to put this in the chat box. The best way to know where a clinical trial says is go to www.clinicaltrials.gov and basically search the disease and search, the city and state. And so if you say Parkinson's disease or progressive supranuclear palsy, Dallas, Texas, and then you'll see, what trials are out there. So you can basically find out. And, I always tell my patients that, if there is a clinical trial that you find and you're interested in it, then let me know, because I can always contact, they can contact the study coordinator, themselves and see. You have to meet the eligibility criteria for inclusion in the clinical trial. Actually, what's really great about this website is the inclusion criteria are on there. So, you can actually read those inclusion criteria, but as a patient, you may not sometimes understand what they mean, but you can always contact the study coordinator. I know a lot of times the study coordinator will just pick up the phone and they'll call and they'll go over the inclusion and exclusion criteria with you. And if you meet the criteria for the study, then they'll say, hey, you know what, come on over. We'd like to do a, pre-screen visit. So look at that website. This got lots of, so basically, besides PT, speech therapy, and other supportive measures, are there anything else I can do for PSP? So, there are some monoclonal antibodies against the protein that is tau, so TAU, that is implicated in the pathogenesis of PSP. And there are a number of different companies that are trying to, look at tau antibodies to see if that can help with PSP. So if you go to that clinical trials website, Mr. Sham, if you tell Jonathan to basically, to go and look up there, that you should be able to see if there is anything, in your area. But for PSP, the things I recommend, sometimes we give people a trial of levodopa. There are patients that respond not as robustly as patients with Parkinson's disease do, but there are patients, they may see some improvement in slowness. I see, patients say that there's improvement in stiffness per se, but certainly if people have neck dystonia and rigidity in the neck, I would give botulinum toxin injections. I have to be careful because I don't want them to get swallowing difficulties. Speech therapy, physical therapy, occupational therapy. Those are, some of the things. But hopefully we find if there's a clinical trial in the area where you are, you can look it up and you can directly. Usually these websites have information about who the coordinator is, who the principal investigator is, and there's an email or a phone call, so you can just call them directly.
Great, and we'll wrap it up here in a second. One or two quick questions. Mary asks, has anyone used a vibe plate for physical therapy? Shilpa, are you familiar with that, or anyone on this Zoom want to address that?
Say that again. Has anybody used a what?
A vibe plate?
Vibe plate? No, I have not used a vibe plate.
Okay.
Eat them small plates.
Again, all of these things are, these devices, there's lots and lots of devices that are out there, but, all the evidence is basically anecdotal for this. Things I hear from patients, unless there is really, and this is not, you got to be really careful, because if your balance is not good, that, this can actually be more harm than good. So, just have to be careful. You really have to, talk to your therapist and see what they think about it. And then, people can always look it up. If there's something that's not within the realm of what I do for a living, I'll look it up and say, and I'll see if it's, something that would be good for a patient or not.
Okay.
But I've never used one. Sorry.
Apple Watch just came out with a new download to their watch that tracks Parkinson's patients when you have off periods and things like that, not just the time when you're in the office.
Oh,
Yes.
very cool.
So there is an app that just got approved, correct, for
Yes.
the Apple Watch. And that is, it's just like those, these are sensor devices. It's like those devices, and it basically tracks, your movements, and it tracks, when are you slow, it's like a lot of those sensing devices. It's just a app that basically got approved, to be used with the Apple Watch.
I like Apple Watches. If you fall, they'll call you. And like when I fell a minute ago, it called me and said, "Are you all right? We detected a fall. Tell us what happened." And I fell, but I'm not hurt.
Very cool. I know, going back to the vibe plate, Luke said that he has had some experience with it. Luke, would you like to share something?
Sure, I've used it more than one or two times. My trainer decided that because that piece of equipment was at the gym, we would use it. It reminded me of one of those machines that they had in the early 70s and 80s, which was like a band that you put around your butt. And he goes, whoa. And it didn't do much for me.
Interesting.
Shake your booty.
Yeah, I kept spilling the ice out of my drink.
By the way, the app is called the Strive PD system. That was basically approved, to be used with the Apple Watch. It's very recent. I just read it a couple of days ago.
Oh, great. Thank you.
And it tracks tremors, it tracks dyskinesias, and it is basically, data in the in basically an iPhone app. So
Got it.
and so this is something that, the honest truth is, it's great to have all of these devices, but, for the time that we have in clinic, anybody that knows me, We get 1 hour for a new patient. We get half an hour for a follow-up patient. And that's plenty of time, for me. But, anything beyond that. So, we've had the PKG device, we've had many devices. And, I can get a lot of information, talking to the patient. If you can get a really good history, and, we basically teach our patients to use a diary, and you can basically say, I woke up at 7 a.m. My symptoms were tremor and slowness. I took my medication at 7. I waited an hour before I ate. It took about 20 minutes or 30 minutes for the medication to kick in. My tremor got 70-80% better. I was able to move very well, and I could tell that the medication lasted all the way until 11, but my dose is due at 11:30, so I can tell that they are wearing off. So I mean, there is but that's what these devices do, for objective data, because not all patients are able to give a very good history. So I think there is utility for them. You have to balance them with the cost of therapy, and recognizing that as much as Dr. Chitnis loves all patients, I can't do a visit, look at an app, and look at the data from the app, and try to make it in 30 minutes. And so there are limitations. So
Absolutely. Karen, would you like to share briefly about the study that UT Southwestern is doing? Actually, let me back up a second. For those of you guys who are on our mailing list, I had sent out an email regarding a study that UT Southwestern is doing for balance and falls and its relation to anxiety and therapy. Karen, did you want to just share briefly about that so that folks can call if they're interested?
Yeah, I'd be glad to. We actually, let me just say first, we have 3 different studies going on Parkinson's disease at Southwestern. And if you think you might be interested, you're welcome to email me. And I'll put that in the chat in a second, and I'll get you to the right person. The study that I'm the principal investigator for is a study for folks who have had freezing of gait. So that's, when you're walking and then you just stop and your feet kind of get stuck to the floor. And we are looking to see if we can make a difference on that with treating anxiety, actually, because it turns out that people who freeze a lot end up getting pretty anxious, many of them. So that's sort of a non-invasive way that we are looking at that, and we're measuring various different things, including anxiety and heart rate and stuff like that. So we're not going to poke you, and we do pay you, not a lot, but you can get a decent dinner out of it, I would say, if you want to participate. It's about a 6-week study total, and it's mostly virtual, but there are 2 or 3 times you have to come in. The other studies I can't speak to as well, but one is a boxing study, and then there's another one with strengthening calf muscles. So if you have any interest in any of those, I'll be happy to be the contact for it, and if it's not for my study, I'll just pass it on to the right people. But thanks for giving me that chance, Shelley. I appreciate it.
Sure. Thank you for sharing. Any final thoughts? I know we're almost at 10 past.
Oh.
Hi there.
Hi, this is Leslie in Montana. Hey, I have a question for you. Quite some time ago, I saw for people who have hypomemia, which is not me, right? But I have a friend who has it, and a device that what happens, apparently there's some system in the body that if you're in a noisy environment, quite often you will speak louder. So what they're doing is that they're piping this noise into your ear, and the person responds by speaking louder. So do you know anything about something?
Yeah, there is another device like that here that I know Price Cleaver also has been using, and it's been used at the VA. I forgot what that name is. I haven't used it. Megan Salinas, one of my fellows, has apparently used it a lot, because obviously, see, the principle is that if you hear a really loud noise, what we tend to do is we want to we speak above that noise. So we are basically, trying to use more intent to speak above the noise. That is really the principle of the device. I don't know how much it costs, and I don't know, is it truly useful? But I can ask Megan Salinas, and the next time they're on, in a month or so, I can try to get that feedback to you if you log on.
I think it might be called Speech Vibe.
That's exactly right. That's what it's called.
Yeah, and about 4 or 5 years ago, I saw it come across when it was in research, and then I found out that the VA was using it,
Yes.
and then just more recently in the States, the Medicare. I don't know how it's reimbursed, or whether they pay a penny on the dollar or whatever, but Medicare is shaking their heads up and down, like, yes, we will work with this system. So I thought, but I don't know anybody who has used it, and
yeah, so Megan Salinas is at the VA, and I will definitely ask her experience with it, because I think she has used it quite a bit. I think they gave the VA a little bit of a concession on it as well. I don't know how it's reimbursed, because I haven't really used it, honestly. But I can definitely find out. Shall you remind me, and I'll find out information about it, and happy to share it with you. And
now,
see,
how would you share it with me? Through my email address?
Yeah, if you're on the Skype as email, Shelly can email it out.
You've registered for this, so I have your
Yeah.
information,
Yeah.
Leslie, and I'm making a
I
note right
don't
now.
know what I've done half the time, whether I put a stamp on the envelope. I don't know. There's a lot of stuff I don't remember doing. So
Yeah, no, but
okay.
I can definitely try to find out about it, because I think the guy who is a rep for the system told me that Megan Salinas has been using it a lot, so she's one of my kids, and so I'll find out and I'll let you know.
Thank you very much.
Yeah, you're most welcome. Okay, Shelly.
Luke, did you have a question? I see that your hand is raised. I don't know if that was an accident.
Because I showed up late, I haven't heard everything you've been discussing tonight. Hi, Dr. C.
Hi.
It's great to see you.
Great to see you as well.
I wanted to ask you about hypoglycemia and how it affects the efficacy of the pills of Rytard.
Did you say hypoglycemia?
Yeah, low blood sugar.
Low blood sugar. What have you seen? I have not experienced, I've not heard from anybody, so low blood sugar should technically not interfere with the absorption of the medication. I'm just trying to reason it out. What is your experience? Tell me, and I'll try to
My
reason it out.
experience is that I forgot completely how badly hypoglycemic I was. And in the last, I would say 4 to 5 months, I've been having major issues with eating exactly right, taking the pills at exactly the right time, not eating any protein. If I don't eat correctly, my medications might as well go out the window. And
Correct. So I'll let you finish before I say anything.
Sorry, it's all to do with my sugar levels. I wake up in the morning, I eat some fruit, and my sugar levels are at a good space. But very quickly afterwards, I'm starting to shake for need of more food. It's not the need for dopamine medication, because I'm normally good from the time I wake up at, say, 6 o'clock until about my first pills I take at 7. But I've gone further than that to at least 9 o'clock, and I feel great. And I actually haven't formulated this question properly. I just blurted it out because I wanted to talk to you.
Keep thinking on it, but let me add a few thoughts. So,
Okay.
So if people have low blood sugars, their Parkinsonian tremor can get worse. So yes. That's one thing that can happen. Luke talked about medication. So that's why when you wake up first thing in the morning, take your pill, take it with full glass of water, so it goes all the way to the intestines absorbed. And the reason to wait an hour before eating anything is because, you know, you don't want food and levodopa to be at the level of the intestinal transporter at the same time. And especially if you have protein. So protein is broken down into small building blocks that are called amino acids. Levodopa is also made of amino acids. So imagine that you have levodopa and protein at the same spot in the intestine, where levodopa is going to be absorbed in the bloodstream and from the bloodstream go into the brain. So protein interferes with the absorption because of the competition. And so people can, you know, absorb lesser amounts of levodopa. Sometimes people don't absorb any levodopa. So people can get delayed on response and they can get a no on response at times. So, you know, protein, I understand, but, you know, I can't understand how there is a correlation between low blood sugar interfering with the absorption of the medication. But I do know that low blood sugar can definitely cause, you know, like tremor to be worse. I've seen people with hypoglycemia, you know, have more tremors. Did you formulate your question?
Not really. It's what you're saying. Normally, when it comes to my ingestion of protein, I don't do protein until night because I know I'm going to bed, and if the protein cuts the pills, I'll be fine. But during the day, I've really got to watch what I put into my body, as if it has any protein. I've found now. I used to think I could get away with plant protein, but pretty much any protein now, within 10 minutes of eating it, there goes my carbohydrate.
Yeah,
and it comes immediately.
Yeah, I think some people are more sensitive to that than others. What I also tell people is that, you know, just because you have Parkinson's and you are taking levodopa, carbidopa, that does not mean that you stop eating protein. You know, you can, just like Luke does, you can basically, you know, decide the meal of the day where you're going to eat, you know, most of your protein. So, you know, some people will basically eat more protein at breakfast time, or some people will eat more protein at dinner time. And as you know, Luke said, that if you're eating dinner, then you're pretty much getting ready to go to bed. Even if you absorb a little less levodopa, then, you know, you're probably okay, as opposed to during the daytime when you really need your full dose of levodopa because you're, you know, on your feet and functional. So yeah, there can be certainly a strong interaction between protein and levodopa.
How do you determine how much protein? You look at the back of a milk carton, 1.5. I don't know how to relate that to a hamburger. Or I like bacon and eggs on the weekend.
Yeah, I don't think it is the quantity of protein. I mean, it's not, I can't tell you the grams. Of course, the more protein you have, the more competition with levodopa. But I think if you take your levodopa, you know, and you take it with a full glass of water, within an hour or less, it should be all the way at the level of the intestine. It should already be absorbed. So if you wait a whole hour and then eat your protein, it's okay, because remember, the protein is first going to stay in your stomach for a couple of hours. It gets digested before it gets absorbed. So, you know, so having that time interval separation really helps.
That's what I do, except by the end of the day, I can't get any, I shouldn't eat any protein. It's like it built up right there and blocked my Terry or something.
Yeah,
I think
but
it's up to 10 o'clock at night.
Don't stop eating protein. I think, you know, you just need to, I mean, let's say that if you're going to eat a protein heavy meal, then you may have to wait more than an hour. Sometimes people wait an hour and a half or more, you know, before taking the medication. It's just, you have to determine for yourself what your system is like. You know, there are some of my patients that tell me that their medication gets absorbed much better if they take it with food. You know, go figure. So I talk to each patient, I let them decide what works best for them. So you really have to figure out, you know, but if you eat a large quantity of protein and you don't wait and don't separate it, you're not absorbing your levodopa,
No,
that's for sure.
I don't do that.
Yeah. Okay, well,
Thank you, Dr.
great
C.
to chat. No, you're most welcome. Nice to see you.
Nice to see you too. Thank you, Shelley.
Okay, Shelley, all yours.
Yep, I think we're gonna wrap it up. Thank you guys for sticking with us. Thank you, Shilpa, especially for sticking with us. I know you're not feeling the best, but we're 20 minutes past 8. But thank you guys just for all of the engagement and the questions and just for your interest and support. and for joining, even though some of you guys only made it towards the end here. Thank you for being here. And this is being recorded, so you can always watch the recording back and share it with anyone that you're interested, that you think will be interested. Quick reminder, our Ask the Doctor webinar is coming up next month in July, in just a few weeks, and registration is open. We will be interviewing Dr. Kathleen Shannon from the University of Wisconsin. We got some questions tonight about GI, inflammation, all that good stuff. And that's one of Dr. Shannon's areas of interest and one of her specialties. So she'll be speaking on that, as well as some up and coming clinical trials and just answering some general questions related to that. So please go ahead and get signed up, skypassfoundation.org. And for those of you guys who are subscribed to our mailing list, I got some messages that you're not receiving our emails. Please check your spam folder to see if emails are getting sent there inadvertently. Our mass emails are sent out from a marketing email platform, and so sometimes it goes to spam. So the from name will be Skypass Foundation, not my name, Skypass Foundation. And please check your spam folder and see if it's in there, and add that to your contact list that you are getting those messages. And of course, any questions, we're here to answer and help you guys. So thank you again. Have a wonderful night, and we'll see you guys soon. And thank you, Shilpa. I hope you feel better.
Thank you so much, Shelley. Thanks,
Thank you,
everybody.
Dr. C.
Bye,
Thank you.
Luke. Thanks for joining
Bye.
us tonight.
Thank
Everybody
you,
have a good
Sarah.
night. We'll see you
All right.
next month.
You
Bye.
guys.
Bye.